Dr. Man, please.
So thank you very much, Mr. Chairman. So, ladies and gentlemen, we also do quite a lot of CTO in my center, but I stand here today quite humble because my case maybe we do not it's not so complex as cases from our expert from Japan or Hong Kong. Or I learned quite a lot from my master, the CTO expert in Vietnam, like Dr. Ngô Minh Hùng or Dr. Hoàng Văn. But I would like to share some cases today that reflects our current clinical practice and our situation in Vietnam. So, so all we know that the CTO operation is now currently on class 2B on the guideline. So, but on the daily clinical practice, we still do quite a lot of CTO, and nowadays we need to do more on the CTO evaluation before we proceed to the CTO procedure, like the previous presentation by Dr. Omar. So all we know about the algorithm to approach a CTO lesion, and for each of you, maybe for us, maybe the most important thing is that we understand the way and how to stop when we could stop in the procedure. So the first case is a 91 years old female patient, and she has history of hypertension, diabetes, and hyperthyroidism, and she admitted to my hospital due to chest pain for 30 minutes, and the chest pain is quite typical for the coronary artery disease. But all we can know that the cardiac troponin and every other aspect of the lab test was quite normal, and under the LVEF, we can see that she has the normal LVEF, and the ECG looks quite a lot to the ECG about LED lesions. But actually, for this case, we really not want to do it in an urgent case. But this old lady, she was the mother of a very important guy who is quite a famous politician. So we was quite in a lot of pressure to do this case because he's a very old patient with no increase of cardiac troponin and no sign of very severe ACS. But we have to do the case quite in an emergency situation. And this the coronary angiography. So. I'm very sorry for the very poor quality of the images, and we can see that they are very quite not so long, but RCA, CTO, and quite moderate lesions on the LED, and we can see quite clear see the collateral from the LED to the RCA. So we have to do quite a bit under pressure to do a PCI on the RCA, and at that time because we was in quite rushing because it was quite late in the afternoon, and my wife was waiting for quite a dinner at night. So we tried to do the case with a JR for only 6 French, and collateral with the Tiger 5 French on the radio. And so you can quite easy to understand the result after quite an hour and a half of trying with several types of guide wire like Cyan Black, Filter XT, or Gaia 1. I really failed to recanalize this old lady. So after a few days, actually, it's quite reluctant to do another time because he's quite very old, and everyone was saying that we was so crazy to open up a CTO for 91 years old female patients. But as I said, we was working under quite a lot of pressure on this case because of the other aspect of the family. So even my echocardiography, when I asked her to do the thread echo for the case, she refused right away because she said that, are you crazy? Because she's 91 years old, better leave her nothing to do. So under the second attempt of the case, we tried a more aggressive and better preparation with the 7 French femoral and try to do a better collateral tracings. So here's so if everyone know, and I think that we learned quite a lot from our Japanese college about choosing the guide wire, and for our strategy, maybe from initially we always choose to use a very soft and tracking wire like Fielder XT, and then we upgrade to Gaia and other kind of stiffer wire, and then if we cannot pass, and we may do the step up or step down strategy. So. And in this case, also we have kind of a bifurcation. Maybe I'm sorry for the quite a poor quality of the video, maybe because of the machine. But for the second time, we try to use another the micro catheter with a dual lumen catheter, changed from 5 cross to Sasuke, which is a dual lumen catheter, because there's a side branch, which is we really know that is a very crucial if you want to do parallel wire technique. And then I use exactly the same as we did in previously. We use a Fielder XTR and then Gaia and failed one more time. And I try to upgrade to Gaia third, but still going to the subintima space. But then we tried a little bit of step down to Fielder XT, and then this time we can cross with the Fielder XT. And in my our experience, I think that the step down with the field XT sometimes is very crucial when we tried a very stiff wire like the Gaia generation to and then this wire escalation, and we managed to finish the K after just more than 1 hour. So with the same strategy, we can finish the case with quite a better preparation, better collateral tracking, and better guide wire, and we use a dual lumen catheter in order to finish the case. So the case number 2 is quite a young male patient. He's quite a businessman. He has history of diabetes type 2 and long-term smoker, and he admitted to the hospital due to chest pain for quite a long time of more than 15 minutes and shortness of breath. And he has done the coronary angiography in the local hospital, but they failed to recognize with the this first attempt. So they transfer us to him to our hospital. So under the lab test, he has the ECG as showed on the screen, and the normal cardiac troponin, and normal liver and kidney function, and LVEF is about 40%. So this angiography showed a three-vessel disease. This is the RCA, shows the CTO at the distal part of the RCA, and under the left part of the coronary, we can see that he has also the lesion for the left coronary system with a CTO of the LAD, and also the very narrowing of the circ. And initially, we really think that this is a case, it is very suitable for the cabbage patient, because he's quite young patient with quite low LVEF of 40% and three-vessel disease, and the true CTO of LAD and the RCA. But when we discussed among the family and the health team, we advised him to do the cabbage, but the patient and family really refused to do the cabbage, and they really want to do the PCI one more time if we could manage it. And we can see that this is a very long LAD, because we really try to open up the hard disk CTO of the LAD, and we have a quite blunt entry point, maybe blur the CTO body, and this CTO score in this case maybe more than 3 points, which show a very difficult CTO case. So after quite about 1 hour of doing anterograde with some kind of guide wire, we still fail with the anterograde wiring, because we can see that there are quite blunt and quite ambiguous of the entry point for the LED. And then after a while of the of the wiring, we really failed. And at that time, we really want to stop and transfer the patient to the cabbage. But then I really think that we still can try the retrograde approach with the septal. And it is quite tricky, to be honest. And we use a Caravelle 150, and the cyan blue, luckily quite easy to come to the distal part of the CTO body. And we try several options to puncture the distal cap, like chain to the stiffer wire like Gaia to try to kissing the wire. And then, but the first attempt was failed, and then we try to do the ballooning of the side branch, try to move the cap of the anterograde Y, and then try to puncture the CTO body from the distal part of the CTO, but we still fail this time. And even we really try to puncture the distal part of the CTO with a stiffer wire like Gaia. We still fail one more time. So at that time it is more than 4 hours, and then we really find it is quite tired, and I really want to stop at this time. But then my master, he really tried to encourage us to do something more, and try one more time. And then we think about the second atom of the kissing wire, but it goes to the subintimal space one more time. And then we try the last resort, which is the card technique. We try to advance the anterograde Y, which is not quite clear in the CTO body, but and then we try to go the retrograde with the two O balloon, and then we try to do cut. But this time, very lucky that the anterograde Y can go to the distal part of the CTO body, and then afterward, it is successful of the Y of the LED, and then finally it is the standing. We put just one stand of 275 by 38 resolute on onyx, and do the kissing balloon for the side branch, and this is the final result, which show quite a favorable result for the CTO of the LED. And then we did the circ and the RCA after 1 month successfully, and this is an old case of a couple of years ago, and nowadays the patient still fine. And so what we learned from the two first attempt failed CTO, firstly, preparation and planning is most important for the CTO success. And sometimes pressure is your fault, because you need to do the CTO in one when you have time and you leisure day, not under the pressure. And sometimes the same strategy, but the better preparation is best when you can success in the second time with a better preparation. And for us, the ratio rate is only the last resort we can do for a CTO. So thank you very much for your attention.
Okay, thank you so much. What great cases. The second case especially, I mean, you kept on persisting and persisting, and